Basic evaluation of a patient with vitreoretinal diseases. The current era of vitreoretina has been increasingly dependent on the investigative modalities like FFA and OCT. But are these the basic evaluation of vitreoretinal disorders? Well, I guess the answer is no for this, because before going to investigations we have to rule out the clinical aspects of the retina. Means we have to check thoroughly the clinical aspects, like we have to do thorough slit lamp examination, indirect ophthalmoscopy. How does one approach to a patient with vitreoretinal disorders? Like we have to do first a proper history taking, then slit lamp examination, fundus examination with 90D or 78D, and indirect ophthalmoscopy. Then comes to the investigations like FFA and OCT. So, what will be our approach to a patient with vitreoretinal disorders? The detailed, well-directed history is a must. Like, you have to ask the correct questions relevant to the clinical situation. Like, suppose if the onset of vision is sudden or subacute or gradual. If it's sudden, like over minutes, so you can think of CRAO, CRVO, or AION as a diagnosis. But if it's acute, you can think of vitreous hemorrhage. Acute means if it is in within hours, you can think of vitreous hemorrhage, retinal detachment associated with PVD. Or if it's subacute, like the vision loss is going from hours to days, so you can think of retinal detachment, microangiopathies like hypertensive retinopathy, diabetic retinopathy, and other diseases, and inflammatory pathologies like Yale's disease, retinal vasculitis. But if it's gradual, so you can think of dystrophies, degenerations, and microangiopathies. You have to check for the progression of the vision loss, like in a situation one, like if it's maximum deficit at the onset, means it is not improving, so you can think of arterial occlusion or ischemic venous occlusion or some neurological disease. If the maximum deficit at the onset is there but it's improved slowly, you can think of non-ischemic or non-central occlusions and neurological diseases. If the maximum deficit is there but it is progressively worsening, so you can think of inflammatory pathology and degenerative diseases. The history of pain is utmost important. If it's a painful loss of vision, so you can think of inflammatory disorders or infective disorders. If it's a painless sudden diminution of vision or painless diminution of vision, so you can think of retinal detachment, vitreous hemorrhage, and cataract. The laterality is also most important. If it's unilateral, you can think of trauma associated with retinal detachment, infections. If it's bilateral, you can think of inflammatory inflammatory disorders or systemic vasculopathies, diabetes mellitus, hypertension, degenerations, and hereditary. The past history, according to the past history, like if there is any history of trauma, you can think of retinal detachment or some macular hole. If there is any history of medications like chronic use of chloroquine, you can think of chloroquine toxicity in the macula. If there is any history of any surgery or laser undergone to the, so you can think in that line. Suppose if the patient has already taken laser for diabetes, proliferative diabetic retinopathy, so you can think of in that line. The systemic history of diabetes, hypertension, and CAD is most important to rule out all these microangiopathies like PDR, hypertensive retinopathy, VRVO, CRVO, or CRAO, BRAO, or AI1. The family history is also important to rule out hereditary diseases like retinitis pigmentosa, FEVR, and history of diabetes may be undetected, but there should be high index of suspicion. Here you have to pick up a subtle signs to establish provisional diagnosis. The relevant investigations can then follow. Suppose in the scenario 1, he is a 65-year-old male with a gradual onset of vision loss. So in the figure 1 you can see clear lens with a good fundus glow. In the figure 2 you can see cataractous lens with absent fundal glow. So this could be the loss of vision here could be because of the cataract. In a case 2, it is a 25-year-old male with a gradual onset of vision loss with a suspected history of trauma. So in a figure 1 you can see the rosette cataract, which gives you the history of blunt injury. In the figure 2 you can see iris hole, which may give you the history, which may lead you to the retained intraocular foreign body diagnosis. In the figure 3 you can see retro-iris abscess. Behind the iris you can see some discharge deposited, so this can lead to the diagnosis of endophthalmitis. In a scenario 3, it's a 65-year-old female with an uncontrolled diabetes with acute painful loss of vision. So in a figure 1 you can see the fibrinous membrane in the anterior chamber along with hypopyon. So you can think of endophthalmitis. In the case 4, this is a 65-year-old pseudophakic male with a diminution of vision for 1 week with a dull fundus glow with fine pigments behind the IOL. In the fundus you can see the retinal detachment along with the horseshoe tear. At times the affected eye does not give you the much clue, so you have to look for the other eye. So other eye examination is of utmost importance. Suppose in a case of recent vitreous hemorrhage, we have to always assess the fellow eye. We have to rule out the posterior vitreous detachment along with retinal vascular blocks like CR, status post CRVOs. They can cause vitreous hemorrhage. Suppose in the figure 1 you can see the vitreous hemorrhage. In that same patient the other eye is having horseshoe tear along with a PVD. Recent vitreous hemorrhage, we have to always assess the fellow eye. Vitreous hemorrhage can be due to secondary to the PDR. So if there is a PDR in the other eye, you can think of vitreous hemorrhage secondary to the PDR as a cause of vitreous hemorrhage in the fellow eye. Again, the vitreous hemorrhage can be secondary to the PDR, so the fellow eye examination is a must. Ultrasound, B scan, FFA, and OCT that will help to establish the diagnosis and the plan of management. Suppose in this case the right eye he is having injury with an iron particle while working. Visual acuity in the right eye was PL and projection of rays. In the left eye it was 20/20. So here in the B scan you can see the retained intraocular foreign body with a back shadowing. So here we can plan pars plana vitrectomy plus foreign body removal. Here you can see the right eye complicated cataract surgery 15 days back with an hazy view, but in the B scan you can see the nucleus drop. So here we can plan pars plana vitrectomy plus nucleus removal plus minus glued IOL. Here in the right eye you can see the total cataract with a history of trabeculectomy. So in the B scan you can see the retinal choroidal thickness along with normal appearing retina. So how to do a good retinal examination? The sequence of examination should be there in the back of your mind. Like we have to first check for the media, optic disc, peripapillary, any peripapillary changes, vessels, the background retina, the periphery vitreoretinal interface, and the macula. Retina, a cup-shaped thin membrane. It has a thickness of 110 microns at the ora, 230 microns around the macula. So what is the ora? Ora serrata is the border between the retina and the non-pigmented epithelium of the pars plana. It does not run in a straight line. It is composed of a forward pointed extensions of the retina, which are called as the dentate processes. In between the dentate processes you have oral base. This is how it looks like, the oral base and the dentate processes. So anatomical landmarks are the optic disc, macula and fovea, the vortex veins, medial and lateral long posterior ciliary nerves and arteries. In this figure you can see the anatomical landmarks to do a perfect retinal examination, to locate a lesion where the lesion is exactly. In this figure you can see the posterior zone, the equatorial zone and the equator along with oral base and the oral zone. Methods of fundus examination: indirect ophthalmoscopy and slit lamp biomicroscopy. So while doing a fundus drawing, the fundus drawing chart, that is the Amsler chart, you have to put it in a reverse direction, like the 6 o'clock position and the 12 o'clock position should be reversed, and it is kept on the patient's chest. This is how you can do the basic fundus examination, and you have to draw the fundus drawing. While looking at a lesion in a indirect ophthalmoscope with a 20D lens, you will see the reverse and laterally inverse images. So while looking in a particular quadrant, you will see the image as a reversed. Like in this figure, when you are looking at a horseshoe tear along with blood vessels in that area, so in the indirect ophthalmoscope you will see inverse image along with laterally reversed image. Again here it is showing same thing. You have to draw a lesion and you have to trace the blood vessels up to the lesion so that you can correctly mark the lesion while doing its treatment. This is the Amsler chart, which will have the posterior pole, the equator, the oral zone and the pars plana. The orange arrow indicates the equator, the violet arrow indicates ora serrata, the blue arrow indicates the pars plana. This is utmost important. The features are basic to drawing of the retina. So the universal color coding we have to follow to draw any lesions in the retina while examining with the indirect ophthalmoscope or 78D or 90D. The attached retina is shown with solid red, detached retina with blue outline and solid blues. The ora serrata is shown with a blue forward dented processes. The disc is shown with red with the outlines around the disc. Macula is shown red if attached, blue if detached. Any opacities in the media, vitreous or vitreous traction in the vitreous is shown with green. The hole is shown as round or horseshoe tear in a horseshoe tear fashion or lattice degeneration with blue outline and dark red in the center. The operculum is shown with solid green for operculum, solid red outline for in blue for a hole, solid red outline in blue for a hole. The paving stone is shown, paving stone degeneration in the periphery is shown as black outline or a brown outline under the detached retina. The traction tuft is shown in blue, cystic traction tuft is shown in blue, lattice degeneration is shown with blue outline with blue hatchings, thin retina is shown with blue outline with red hatchings. Peripheral cystoid degeneration shown with blue circles at the ora, schisis blue outline with blue cross hatches, cyst in the retina blue outline with blue shading and blue cross hatches. Pigment in the retina or under the attached retina is shown as black. Pigment under the detached retina is shown as brown. Preretinal membrane is shown as green crosshatch. Star folds as blue lines. Zonular traction tuft as blue. Meridional folds as blue. Arteries are shown in red. Veins in blue. Ghost or occluded artery red dash, ghost or occluded veins blue dashed, silver wiring in a silver or grey color, sheathing yellow over red or blue line, flat neovascularization orange, raised neovascularization purple. This is you have to keep in mind for PDR patient. If it's a flat neovascularization, you have to show it in orange. In a raised neovascularization, like the if forward NVD or forward NV, you have to show it in purple. Exudates are shown in yellow solid or black hatchings. Cotton wool spots, yellow outline with black C's. Retinal hemorrhage in red vitreous hemorrhage is shown in red and green. White vitreous hemorrhage is always shown in green. So a fresh vitreous hemorrhage, you can show it in red and green. While a white vitreous hemorrhage, you have to show it in green. Sunburst sign, that is sickle cell tissue, is shown in black. Retinal edema is shown in blue shading over the red, solid red and no outline. Cystoid macular edema is shown in blue circles. This is one of the representative figure of how the lesions you can show it in the Amsler chart. Okay, so you can see the fixed fold, the pigment under the detached retina, CRA in a detached retina, vitreous condensation at the edge of the lattice, which are shown in green color. Lattice is shown in blue hatchings with blue outline. Vortex vein you can see with red. Chorioretinal atrophies is shown in brown. Thin retina is shown in brown. Vitreous opacity is shown in green. Operculum is shown in green. Posterior staphyloma area is shown in brown. Horseshoe tear you can see it in red with blue outline. This is again a representative diagram of how the lesions you can show it in the Amsler chart. That yellow colors indicates the macular edema Yellow dots in the macular area indicates the macular edema or exudates. Sheathed vein is shown in blue center with yellow outline. Again, a choroidal tumor, you can show it in brown. Retinal edema due to the laser around the break, you can show it in yellow. Buccal effect, you can show it in black. This is a case, this is a GRT, you can show it in red. Rolled edges of the GRT, you can show it in blue. CME in the attached retina, you can show it in blue circles. Here you can see a flat NV which is shown in red. The raised NV is shown in purple. This is a vascular lesion with an hemangioma which is shown as red. A detached pars plana epithelium. Attached retina is shown in red. Detached retina is shown in blue. Horseshoe tear is shown in blue outline with a red center. Lattice with holes are shown in blue outline with blue hatchings with smaller holes as red color in the center. Always record the landmarks that make the holes easier to find at the surgery. Folds, pigment, hemorrhages, vortex veins and vessels can serve as the landmarks. The aura should be drawn only if it has been examined. To summarize, FFA, OCT, etc. are essential but don't form the basis of diagnosis of all clinical vitreoretinal disorders. A good clinical history and examination forms the foundation of your diagnosis and management. Proper documentation of findings helps both intro and in the follow-up of the patients. Thank you.